So basically at this point in time, we need to figure out where the limitation is to vision. I don't see that it's her optic nerves. Her pressures are not high. Her optic nerves look very normal. She does have some evidence of some thinning of portions of her retina. And if this is an autoimmune condition, it probably was going on before the dental. And I suspect that maybe she was on the cusp of having a problem, but she had adapted to her home. Then she went under anesthesia. Then she came home and she was struggling because she had, probably was already vision impaired, is my suspicion. And the only reason for that is, yes, it could have happened after the dental, but if it happened after the dental, it doesn't usually have a fast onset. It seems fast, but probably this disease goes on for a while before it actually reaches the pinnacle where they can't see. And so again, taking them out of their home, anesthesia, sometimes I think if they're already struggling, then that really makes things very stark after the fact. But I see dogs that have been okay, and then it seems like they suddenly go blind, except for when we look back at the history, they were doing some things that were not quite normal. So basically, if it's possibility of brain or eye, the test that we choose is an electroretinogram to check the rods and the cones. And that's a test we do before cataract surgery because we can't see the retina in many of those cases, and we need to make sure the retina is functioning well. And basically, when we do the retinal test, if the retina is normal, the problem does not lie with her eye. So some of these changes I see could have been there for a long time. We've never gotten to see her before. Nobody's ever had to look at her before.
Right.
But if her retinal test is normal, I'm going to send you to neurology. If her retinal test is abnormal, that fits with this being an abnormality associated with the function of her retina. And that's where we kind of then talk about, do we want to try and treat her with medication to address an autoimmune condition? Some of those patients will get some function back, but I think those are some things we have to figure out. First localize the problem, then figure out where we want to go from there with treatment.
Okay, so what you're saying is it could possibly be this.
Yep.
Or it could
be something in the brain, possible. Maybe she had anesthesia, we don't know. But I do see some subtle changes in her retinas, which makes me suspect it could be retina, autoimmune. But I would not treat her. The test is going to be the fork in the road. The test is going to be what helps us figure out and localize where the problem is.
Okay.
Functionally, okay? It literally is that fork in the road of, okay, well, if the retina is good, then we got another bigger problem. But if the retina is the source of the problem, that's what we're looking at.
So let's say it's the retina.
Yes.
With treatment, can she recover?
So the hard part is, like I said, I find this is a disease that we identify at end stages. Because I think it's been going on a lot longer than we ever realized. They're adapting as it happens. It's like having a dimmer switch being turned down ever so slowly. So I have had patients that get vision back, but I usually feel like the chance of recovery is 20% or less.
Because she's getting older too.
Not age, but just the duration. Because the longer that disease process goes on, the more it affects the health of the photoreceptors, the rods and the cones. And you're treating, and people get immune retinitis, and it's a very slow onset disease, but it's a very slow offset disease, meaning once you start treating, yes, some people will be treated for weeks and months. It's just not something that just gets better fast. So number one, we decide if we treat. Number two, how long are we going to treat? It's medication, and if we can, maybe sometimes we'll recapture a little function in one eye, but it's not a very it's all the damage has already been done by the time we start to treat them. And that's the hard part. So I'm not opposed to treating at all, but I always want to just say that, I just have to make sure that, if we treat, we know that there's a chance that there's enough change already that she won't recover her vision. We need to make sure we're treating her and making sure we keep her body in mind so she's safe and healthy, right? Because every drug has side effects.
Okay. With treatment, is it oral?
Yeah, usually pills.
Okay.
Yep.
All right.
Okay. So that's just
and with treatment, is it lifelong?
Very possibly. So if we recover vision. So what I usually say is, I used to treat dogs for 2 months and see if we would get a recapture anything. Well, then I had dogs that people were like, well, I just want to keep treating. And then I had a dog that came back at 4 months and she had her vision back in one eye. So I think it's trying to be judicious. I think it's trying to, not give up, but be realistic. So I feel like I would think about a time of some maybe 4 to 6 months of treatment. Again, we need to make sure that her body's tolerating the medication. If we don't have vision by then, we may say, okay, we're done. We're not going to keep her on medication long term if we don't know that it's doing anything for her. And if she does get something back, she's going to stay on meds because otherwise it's going to come back again.
Okay.
Okay.
What about the drops?
So the drops, I mean, they're not hurting anything. I can't identify anything that this was ever a pressure issue,
Oh.
which is good for
So,
her.
not a pressure issue? Because that first night, my neighbor across the street,
Yeah.
when he looked at her, her pupils were dilated.
Yeah, this condition makes the pupils a little dilated, and her optic nerves look normal.
Okay. And,
And her pressures are 6 and 11.
yeah, but that night, he says the pressure looks about 30 without measuring, but just by visual. Okay.
You can't know unless you measure it
Yeah.
online.
The next day he measured it, it was like 10.
Yeah,
Okay.
so
All
that's
right.
normal.
Okay.
Okay, so you have to, I'll get you an estimate for the electroretinogram. We'll figure out logistics and decide if that's something that you want to pursue so we can get an actual reading about what's happening with the function of her retinas. And that's something you could do now. It's something you could, think about and decide when you want to get rolling with that. We just need to try and get an idea about what's causing her dysfunction, and that's the place to start.
And the redness in her eyes?
Yeah, interestingly, I see a lot of dogs with immune retinitis that have redness. She's more in her right eye than her left. Her pressure's lower in her right eye as compared to the left. Some of it can be
I
medication.
noticed that in her eye, because it tends to want to close.
Yeah, some of it can be medication irritation. She has a little bit of crystalline degenerative change in her right cornea. I don't see any active ulcer on her eyes, but sometimes those things can affect her. So in part, it would be interesting to say, well, whatever day we do the test, should we take her off the glaucoma medication, then test her and check her pressure again that day? So we have a little bit of, there's some strategic stuff we could do. So, potentially the ERG could be done today, but the reality is we're going to want to stop the anti-glaucoma medication and check our pressure again after, because we need to make sure we're safe as we do that as well. When they come on medication, I can't know what all the numbers were, but we need to make sure we do a good job
So
of
should
that.
I stop or should I continue?
It will depend on what we do at the plan for the ERG. Okay, if we're going to do the ERG, we can either do the ERG today, and then we're going to need to check. If we stop the meds, we'll have to make a plan to bring her so we can check her pressure again. If you said, well, listen, I'll do the ERG next week, then maybe we'll make a plan to when to have you stop it so we can reduce it strategically so we can use that information.
Right. And then I also use artificial tears.
That's fine.
In between.
Yep.
Should I continue?
You can absolutely. Yeah, you can totally do that.
Okay.
Okay. So let me get you the information on the ERG.
So what you're saying is it could possibly be coincidental.
I totally believe it could be coincidental.
When I
It's
took
possible.
her in,
It
she
is
was
possible.
fine. She was running around
Yeah.
chasing squirrels,
Yeah.
birds, and the mailman and the gardener, and all of a sudden, boom, loss of vision.
It could be. I mean, because again, I think that they're so good at hiding it sometimes. They've just adapted to their house. They know where they're going. And then there's something that changes it. And then,
But it's completely overnight. I wave
Yeah.
a piece of steak and she normally jumps up with her hind legs and
Yeah.
grab it.
Yeah.
Now she doesn't even
Right,
look at it.
right. And I think we're further away from the episode now even. Again, what if she was unsettled in that period afterward and she was still declining? I mean, that's possible. It's possible she got worse between then and now too, because probably this was going on. But I will know more once we check the retina. Okay? And I think that's the next piece.
All right.
So what I know about this disease is it doesn't come on, and usually what we find is one eye's probably already been affected, the other eye may be starting to struggle, and then if there's a short period of time where they go from where they're quite functional to where they're having a problem, it seems so sudden to us. But I've seen dogs that I see that are blind in one eye and seeing in one eye, and then they go blind in the second eye, and it seems like very fast.
Right. Well, that's understandable.
Mm-hmm.
But this one was overnight.
Yeah, I understand. Yeah, I mean, it again.
Right after the treatment.
Yeah, but there's nothing about what would happen in a dental that would make this accelerate to our knowledge. But again, it makes me suspect it was already there, and we could have been hanging on by a thread at that point in time. It's just, that's hard to know. So again, electrical test is the next step, so we can actually make sure that what we're talking about is real, because we don't know that yet. Then we figure out where we go from there.
Okay. All right.
Okay, because again, like I said, she has changes in her retinas.
And how long is that electrical test procedure take?
It usually takes a couple hours. We have to dark adapt her, and then sometimes we end up checking her more than one time. So it's usually something where she gets dropped off. She hangs out with us. Sometimes she needs a little sedation because she's active when we do her exam.
Is it like
It's like an EKG for your heart, but it's an electroretinogram for your eye. So numbing, contact, a little electrode under the skin, shine a bright light in her eye. But she needs to be pretty still while we do it. She doesn't have to be under anesthesia, but sometimes we give a sedative so that they're more relaxed, because otherwise it's a lot of background noise if they're moving and shifting around and things like that.
okay.
Okay.
Alright.
So you can think about that.
We'll probably have to do it another day.
Okay, that's fine. I understand. So again, strategically, when we figure out if we're going to do it, I want you to stay on the meds for now. I just think it's safe, and there's no reason I would have you stop it. I think whenever we're going to do this, we should
Plan to.
Yes,
Yeah.
like 48 hours before, I'll probably have you stop it.
Yeah.
Just because I think then we'll get another time to measure. Then you don't have to slip back again. I just feel like, you know, I think until we have a plan, I think 48 hours before you come back, I think we should stop the pressure med. For now, I think we go ahead and let's just keep her on it, and then we can plan whenever we're going to do the test. Okay.
Okay. So
Take this. This
a little
is
bit
just some
more, a little bit
information.
more of this SARS. How does a dog get that?
It's autoimmune.
Okay.
So it's an abnormal immune response directed toward the retina.
Okay.
Okay. So people get immune retinitis. All right, and it's similar. We feel like those conditions are very similar in people and in dogs. We don't know the trigger always. You can go searching and looking for infectious causes. You can get a chest X-ray. I think we first need to do the test to make sure that this is what it is.
So if it is this,
Yes.
it means that she was born with it.
No, sir. It means that she has an abnormal immune response attacking her own tissue.
Oh.
That didn't come when she was born. It came sometime in the last probably
How could it?
weeks to months. Autoimmune disease is an abnormal response of your body to your own tissue. Can happen with people with lupus, whatever the trigger is, and we don't know that in every dog. Could be allergies, could be something
Food?
that causes inflammation. I don't really know that we've identified
Because I
exact.
changed the food on her after I gave her.
I don't really
soft food.
expect food to be it. I mean, sometimes we look for systemic causes. Again, we do infectious disease testing, do a chest X-ray, do an ultrasound. We're trying to find underlying causes that could have contributed to this or triggered it. Some people think allergies can do it. So something in your body. Now they're thinking MS is caused by a virus. Like, so, you know, first you have the virus and then later you may get MS. So that's an autoimmune response because your body's attacking your nerves. Okay? Similar thing. First, we need to make sure that's what this is.
Okay.
Okay? Because we're having I totally understand you have a lot of questions, and this
Yeah.
talks about that.
I gave
But
her food.
first-
I changed her food, and then the antibiotic after the treatment and the painkiller.
Yeah. Again, I think this was probably already going on. I don't think this was triggered by those medicines because it doesn't really totally fit with the timeline.
I see.
Okay? If that's what this is.
Okay.
Okay? So I'm gonna get some information for you in the test. Let's figure out when we're gonna get it set up. We'll strategically stop the dorsal timolol 2 days before you come back. And let's get rolling on getting a plan together, okay?
All right. Thank you.
All right, you're very welcome.
Okay.
Nice to meet you. I'm sorry to do these circumstances. Let's go get her for you, okay?
All right, thank you.
Thanks so much.